Yeah, go.
Okay, hi Lucy. Lucy, can you explain to us what's going on right now? The Health and Social Care Act has been law now for almost a year, and we thought surely that's all going to go ahead. And all of a sudden there's a lot of movement, a lot of anxiety and a lot of agitation around something that's happening in Parliament that's going to have a big effect on the National Health Service. What is it and why?
The Health and Social Care Bill was passed in the form as if it were an aeroplane with no jet engines. So the structure was all there. Its significance was not very plain to many people, unfortunately. They looked at it and they couldn't really understand what they were looking at, and they couldn't find the thing in it that was actually going to accomplish the privatisation. Because really the only marker of it was a little clause explaining that regulations would be issued. And now those regulations are with us, and those regulations provide the jet engines to make that privatisation go ahead. So all of the rest of the plane was put in place last year, and now at the very last minute, before this whole thing happens on 1st of April 2012, the regulations are coming into place to show that everything has to be put out to competitive markets by CCGs and the National Commissioning Board, and therefore that will create rights for private providers to supply, which will not only allow them to take quite a lot of the share of the NHS budget for their business right now, it also potentially makes the privatisation irreversible in the future because they have rights that they can sue on, created by the form of these regulations. They would not exist unless these regulations come into force.
Okay, that's a lot of information, huge implications for our National Health Service. For somebody coming to this question fresh who's very concerned, what does this mean? From April the 1st, what will this mean for them accessing services, and how will it unfold over the next few years for them?
Okay, now we're familiar with the kind of Big Bang privatisation model. There's a lot of different ways that have been developed by the privatisation specialists around the world over the couple of decades since the big privatisation push has been happening. And we're not going to have a Big Bang privatisation for the NHS, we're going to have a very quiet one. So what has happened is that all of the rules that control health financing have been gradually changed since the New Labour times, piece after piece put in place with different explanations for each item as to what the purpose of it was. But overall we now have the NHS reorganised in such a way that it can be relaunched as a mixed market, what is called, so not just a public health sector service, also a healthcare industry. And the rules are structured in such a way that there will be a gradual transition between those two groups. The public sector will shrink away and the private sector will grow. But because there will never be an announcement in Parliament that the NHS is privatised, and because the private providers will be allowed to use the NHS logo for anything that they are getting NHS funding for, it is very likely that the general public will not be aware that the private sector has in fact come in and taken over whatever bits of the NHS it finds profitable, until probably service provision gets very bad. But at that point, of course, the private providers just take the NHS logo off, and then they will enjoy the boost to business that will come with the terrible reputation the NHS will have by then.
Lucy, you made reference to a mixed market in the National Health Service in the near future. Why is this such a bad thing?
Well, you know, it sounds like a good idea to have diversity and options and these kinds of things, and that would be fine if it weren't for the fact that the rules of the market are thoroughly stacked. Because the thing is that if you're organising healthcare, both theoretically and practically, we know absolutely for certain that organising the thing as a public sector service is the cheapest and most effective way of providing healthcare. And that is broadly because the market model does not at all well fit healthcare. The market model depends on a tension, a power balance between a consumer and a supplier. And that market model also includes assumptions that both parties are in possession of all information about, you know, the subject of the transaction. Well, that's clearly not the case when one goes to the doctor, because unless you're also medically trained, what you're wanting to know is what it is that should be purchased to improve your health, as well as, you know, making an arrangement to do that. So in markets where that's the situation, where the consumer has to rely upon the supplier for guidance, what you get isn't a market that clears down to a minimum price and is efficient. What you get is soar away inflation and abuse within that market. Now, that is theoretically the case. A Nobel Prize winner published on that in 1963. It is known by all proper health economists. We also have a large amount of evidence from many countries around the world. Of course, the US health system is the most salutary warning to us, but there are an awful lot of other countries which have been had their health services privatised over the last couple of decades. Basically, there's been a sweep of privatisation of public services right around the world, applying standard solutions. And we can see that when that happens, the consequences are terrible. And in fact, there's a very interesting example in China, where as part of the market reforms, American consultants were invited over, and they made a lot of recommendations about marketising the health system, in fact, probably privatising it. And the Chinese government took the marketisation advice, but not the privatisation advice. So we there have a 30-year-old, fully state-owned, marketised health system. And interestingly, it has exactly the same problems as the US health system. It's not actually necessarily predatory behaviour by companies that are making the problem at all. It's the incentive system. If you pay doctors only when they do work, then they overtreat people. If you make sure that medical facilities have no way of making any money other than by selling things, then they become salesmen, not advisors and advocates to the public. So that's basically the problem with it. The set of incentives that have been loaded into the NHS in order to enable the creation of a mixed market, at the same time completely undermine its ability to be an ongoing decent public service. And actually, you know, in the world, we have one of the very best public services, and compared to other developed countries, it's also one of the most cost-effective. There were several of these in Europe. Sweden's has been privatised, Spain's has been privatised, ours is being privatised. In fact, on 1st April 2013, that is also the day the Spanish government signs over control of its national health service into the competitive market.
Can you enlighten us with any detail of those countries that are ahead of us on privatisation, such as Sweden and Holland? What has been their experience? Is there anything we can learn from that? Does it tell us anything useful?
We are starting to see research evidence emerge. Unfortunately, the privatisations are mainly too recent, so work is being done on sort of systematic research on this. But we do have some early indications. We have news from Holland that because their health system is now run through competition law, GPs have got into a lot of trouble for attempting to cooperate, and other doctors, to work between doctors to coordinate patient care, because that's anti-competitive. It looks like arrangements between commissioners or arrangements between providers, and it's illegal because it's anti-market. And there actually has been a big case on this in which their National GP Association attempted to do something about the fact that doctors are usually keener on setting up in sort of pleasant urban areas where their partners can get work, where their children can go to nice schools, that they're, you know, sort of connected kind of places where there are career opportunities also. So in every country, it is always hard to get people to go out to rural areas and work there. So the Dutch GP Association attempted to make some arrangements such that new GPs would preferentially be encouraged to go out and work in the rural areas where people were not being able to access proper care. That's anti-competitive. It involved interfering with the market, so they were forced to stop doing it, and they were made to pay 7.7 million euros for their offence of competition law, because this was held to be a very bad offence, a very bad breach of competition law. So that's £6.4 million against the National GP Association for attempting to assist patients who weren't able to access care. So that's one worrying example. We're also starting to see the picture in Sweden. And again, we're seeing this shrinkage away of services in rural areas compared to urban areas, and in rich areas as opposed to poor areas. So of 196 new providers in Sweden, none of them went to very poor areas, one went to a medium area, and 195 went to rich areas. All of those were new private providers. A lot of the public providers have disappeared, and those are the people that were providing those services. So what we are getting is an extreme example of just a polarisation of service into urban areas. This is to be expected from the theory, and that's why it's showing up fast in both Holland and in Sweden. In the Spanish system, I spoke with a Spaniard who was very worried about this a few days ago, And she informed me that they have already put in user fees. There's a standard plan, and they haven't told us what all the plan is. They're trying to stop us finding out until everything gets in place. But the later stages of the plan involve user fees. And that means that people who can't come up with €1 every time they need to go to the doctor are not able to see the doctor any longer. Anybody who's not registered with the system, so that includes various kinds of immigrants, can't get access to care at all. Anybody who is over 26 and has never held a job, apparently even if they are ill or disabled, is no longer entitled to access to public care either. Most people are required to rely on employment insurance, health insurance paid for through their job. So outside that system, people are expected to buy private health insurance. We're already starting to see some level of suffering from that in Spain, but it's very, very early days. We can expect things to develop the way that they are in the States, where you have a situation where a large percentage of the population is just permanently excluded from accessing care. A further proportion of the population has insurance which turns out not to be adequate to pay out when they actually need to use it, so they're effectively in the same position except that they've already paid an insurance company for nothing. If people who do have effective insurance, if there's something slightly wrong with them, then typically the insurance company will pay out without question because that keeps the consumers happy. But if something goes badly wrong medically, such that there is going to be a large bill, then the company is faced with a situation where if it can avoid paying that money out, it gets to keep the money. So basically, the money to pay out the insured people is coming directly out of profits, and so they will fight not to pay it out. They get lawyers onto it, they get doctors onto it to try and knock out the case that people have for being able to claim. So between that system and the exclusion, and the fact that people who do have comprehensive care, the hospitals have a field day because finally somebody can actually pay some sizable bills, so they take the opportunity to get as many tests and procedures on those people as possible. You can kind of see that the whole system really is not fit for purpose. The idea is to provide healthcare for the population of a country, so you exclude part of them, you cheat another part, and some die because of it. It's just not a good system, which might be excusable if the government's claims that it will be cheaper were actually true, but it's, of course, several times more expensive as well. It's really very interesting when the government are telling us that this is a good thing to do, the subject of that sentence always disappears. It is certainly very good for somebody to do this, but I'm thinking it's not us.